right, so good evening everyone and welcome to the fourth webinar of the Cornea Club. Following on from our previous sessions on corneal topography, femtosecond assisted corneal sculpting and lamellar keratoplasty, we are here with you tonight with another interesting topic on managing infectious keratitis, which is one of the most common corneal issues any ophthalmology will have to deal with in their practice. For tonight's session, I would like to introduce the moderator of the Cornea Club, Mr. Mohamed Elalfy, who's consultant in corneal surgery at the Corneoplastic Unit and Eye Bank at Queen Victoria Hospital in East Grinstead, UK. Hi, Mr. Elalfy. And our speaker for tonight, Professor Dalia Said, who is a consultant ophthalmologist and cornea specialist at Nottingham University Hospital and an honorary clinical associate professor at the University of Nottingham. Professor Said has extensive experience in cornea surgery, refractive surgery, and ocular surface disease, while also being highly experienced in eye emergencies, and is actually the lead for eye emergencies at Nottingham University Hospital. So it is quite obvious that she has a vast amount of clinical experience in managing corneal infections from the outset, especially complex corneal infections, and we will be sharing tonight her wisdom on management of these situations. So another thing is that Professor Said has also done a lot of academic work and research in corneal infections, including the use of crosslinking in these conditions, and she will be sharing her expertise on that. Now, for those of you joining us for the first time, a reminder that you can keep informed of the Cornea Club activities through our website and Facebook page, and you can watch the recorded webinars on your YouTube channel. We welcome your questions and participation through the Q&A option at the bottom of your screen, and we will try to discuss them at the end of the session as time allows. Now, our session tonight is also live streamed through our Facebook page, and we would like to thank Medicom Healthcare for sponsoring our event tonight. So I will now hand over to Mr. Elalfy.
Well, thank you, Artemis, and I have the pleasure to welcome Said, and thank you, Dalia, for accepting the invitation. And just to add, it's been a long time since I've known Dalia. She's been my first mentor, the first person who taught me what cornea is. I'm talking 15 good years ago, and she was co-supervising my PhD on crosslinking infectious keratitis as well. She's a very good friend. So without further ado, please, Dalia, if you can take us on your roadmap to managing infectious keratitis, please.
Thank you very much. Thank you, Mohamed. And it's my pleasure and honor to participate in this roadmap to managing infectious keratitis. So why is infectious keratitis is considered very bad? We know that from the WHO reports that corneal scarring is the most single important cause of avoidable blindness. Almost about 15% of the world's 39 million blind people is due to corneal infection, and it is the third most common cause of blindness altogether. We know that contact lenses are on the rise, and there is more increase in fungal keratitis as well as acanthamoeba keratitis, especially with the increase of contact lens wear. And it is bad because there are challenges in the diagnosis, and especially if there are mixed infections. We have now increasing problems with resistant strains. We have problems with creating new surgical planes with LASIK, with lamellar corneal surgery. And we have promising but not highly specific therapeutic modalities. And eventually, after we've done all that, we end up with unavoidable scarring, which requires further visual rehabilitation. So we know that with Pseudomonas, you can get a very severe infection in a matter of 8 to 10 hours. And sometimes you get multiple fungal infections. For example, that patients who had Aspergillus infections, and eventually we discovered that he's also got Candida. And especially with viral infection, it can be missed. So if you get a viral infection and you get secondary bacterial or fungal infection, you treat the bacterial and fungal infection, and the patient will get worse, but will get better than eventually get worse because there is an underlying viral infection. And acanthamoeba specifically is quite challenging because it has many multiple presentation from very little epitheliopathy. Limbitis is quite common with acanthamoeba, and it can be an early or late signs. But the pathognomonics is keratoneuritis. If you see perineuritic infiltrate around the corneal nerves, and that is pathognomonic for acanthamoeba. You can also get quite atypical keratitis, such as infectious crystalline keratopathy, where you see these needle-like crystals in the absence of immune response. And they are quite common if the patient is immune compromised, or you've been giving steroids for a long time, such as post-grafts, or the patient's had multiple viral infections. So the immune response of the patient is dampened, and the bacteria will colonize, and you can see it here within the corneal lamellae without any immune response around it, and they are quite difficult to treat. You can also get some forms of atypical keratitis, such as the most common of them is the mycobacterium, which is quite common after laser refractive surgery. And you can also get nocardia, which appears like a wreath-like pattern and quite sensitive to amikacin. Actinomyces, you can see it on gram stains, and it is responsive to penicillin. And mycosporidia can present with keratoconjunctivitis or superficial keratitis. These are all very rare but atypical forms of infections and quite difficult to diagnose. Then eventually you may end up with melting and perforations. And if you get perforation without much infection, you're lucky. But if you get a perforation in the middle of an active infection, then you've got a big problem to deal with. And the sclera can get involved, especially with some very virulent bugs, such as pneumococcal infection, like in this patient, or this patient of acanthamoeba keratitis who had a therapeutic graft and eventually had scleral infiltrate as a recurrence, or with fungal infections which can extend into the sclera. These patients will have to have systemic treatment and systemic suppression as well. We also are creating so many new artificial planes. So example, that patient with fungal infection after LASIK, and the microbiologists give us a very rare fungal called rhodotura. So these artificial planes, the infection goes very quickly in these planes and can spread and very resistant to treatment. And again, this patient has had a DALC and had an infection from the DALC, from the suture tract, and then entered and spread quite extensively. But eventually it was, the sutures were removed and the infection was treated and the patient settled. But also it can happen with endothelial keratoplasties, like this patient with DSEC who presented a few months after the operation with a hypopyon. And you can see the infection started here at the wound. And if you look very carefully, you see these lines there. And these lines were the clue for us that this is a fungal infection. So again, they spread very quickly at the interface, and we've given the patient intensive antifungal, and the patient cleared and back to normal. So these interface infections are very good to be treated if you can discover them early, because otherwise you may need to repeat your grafts. And after you've done everything, you end up with a scar. So you still need to do further surgical procedures to try and get the patient to see well, and further visual rehabilitation. So these are the problems with infectious keratitis. So how can we make bad better? So we have to go back to basics. We have to take a thorough history, thorough clinical examination, use all the diagnostic tests that are available to us, start with medical therapy, and then we also have to augment sometimes with surgical interventions. So history is very important for early diagnosis. So always ask the patient if they are contact lens wearer or not, because your treatment will change depending on whether the patient is a contact lens wearer or not. And how many times or how often you bring the patient back is also guided by this. Always ask for a history of trauma. It can be organic or metallic. If it's an organic, then you have to have a very, very low threshold of thinking of fungal infections. For example, this patient had an organic thing stuck to his cornea, and then we've removed it, and then there was a little bit of fungal infection underneath. Always think of ocular surface disease, especially ocular superficial fibroids. So don't forget to look into the lids and check the phonesis. Ask of a history of cold sores, because if you can see dendrites, or you can see edema, or you can see these neurotrophic ulcers which are not healing, then think of herpetic infection. And nasolacrimal obstruction can be a very, very important cause for recurrent keratoconjunctivitis. So always don't forget to press on the sac, and sometimes you need to syringe to check if there is nasolacrimal duct obstruction, especially in chronic or recurrent keratoconjunctivitis. Check your eyelids. So look at the lashes, look at the meibomian glands, check the conjunctiva for papillae or follicle, because the papillae, if you see them, can be the reason why you get a shield ulcer. So that patient will not respond except if you give them steroids, and sometimes they need antibiotics, and sometimes they need removal of the shield. And you wouldn't have thought about this if you haven't turned the lids and looked for papillae. And again, follicles can be also a clue to this patient who's had subepithelial infiltrate and was misdiagnosed as acanthamoeba keratitis. So again, check the limbus. So then once you've done your lids, then check your limbus. Very important to look for limbitis. It can be there with acanthamoeba keratitis or viral keratitis. But if you see the pathognomonic perineural infiltrates perineuritis, then that is a pathognomonic sign for acanthamoeba. So then you go into the cornea and you go systematically to first look at the corneal epithelium without fluorescein and then with fluorescein. And you can see this pseudo-dendritic appearance, which looks quite different than the dendroids in a patient with acanthamoeba keratitis. Now, the corneal stoma, when you look at the stoma, you have to remember that the infiltrate may be different in size than the ulcer. So that patient had that much infiltrate and a much bigger ulcer. So don't worry, because when you're treating the patient, the ulcer can get bigger, but the infiltrate will get smaller, then that's a sign of improvement. So you have to check the infiltrate and separate to the ulcer and document each separately. And also always use a thin beam to check the amount of thinning that you have. And don't forget to put 2% fluorescein, because if you use the diluted fluorescein, you might miss a leak. So you have to use 2% fluorescein so you can check for CD positive and check for leaks. And remember that if you have a flat AC, you might not be able to detect easily a leak. So it's worthwhile, if you check the pressure and you see that the eye is soft, to press on the eye, and when you press, then you will see the leak. Now, check the endothelium, do trans elimination, look at your AC and look at the iris. And if you have KPs and they are pigmented, then you know this is old. But if you see new KPs, then you know there is activity and there is something else going on that you have to look at. And check also for hypopyon. So if you have an inverted hypopyon like this one, or if you have a plaque like on the back of the cornea, then these are signs of fungal infection. Don't forget the intraocular pressure and corneal sensation. Very important 2 points in managing infectious keratitis, because the inflammatory reaction can clog the trabecular meshock, and then the pressure can be high, and that needs treatment. And also, if you have no corneal sensation, then you know that the epithelial healing will be compromised. And you have to think of corneal sensation not only in the area of the infection or the area of the ulcer, because the corneal sensation is likely to be reduced in that, but also in all quadrants of the cornea as well as the conjunctiva. If you have a confocal microscopy, that's superb, because you can early diagnose acanthamoeba keratitis. If you see these bright spots, or you see these double wall cysts, or you see these signet ring shapes, then these are all pathognomonic for acanthamoeba. But not if you only see one or two. You've got to see like a cluster of them. And usually if you see it in the stoma, then that's much more significant than if you see it only in the epithelium. Fungal keratitis is also very useful to use a confocal microscopy, because you can see the intrastromal bright filaments, and you can see the dendritic cells activation. So it is quite useful also in diagnosing fungal keratitis or mixed infection where you have a fungal element. OCT is quite helpful, and because you can see if you have a plaque, and you can see that the amount of thinning, and you can monitor your treatment. And not only that, but if you end up with a scar, you need to know how deep this scar is to decide whether you want to rehabilitate with a PTK or rehabilitate with a DALC. Or even better than both of these, if you can put a rigid gas permeable contact lens and the patient can see better, then it will be even much better. So it is very important, if you have a sight-threatening infection, to stop all treatment and swab. Take swabs and take scrapes and use gram stain and culture. And if you have PCR, that's even better. You can use impression cytology sometimes in viral infection and send for histology. And if you're not getting anything, the patient's getting worse, then you need a corneal biopsy. And usually when you do take a biopsy, you use the biopsy punches. You take one for microbiology and one for histology. So when you're taking swabs, it's important to remove all the discharge, because then these are dead cells and you're not going to get a result from that. So remove all the discharge, even any loose epithelium, just don't take that, and you have to actually scrape from the bed of the ulcer and the edge. So this is an example where corneal biopsy showed acanthamoeba cysts from histology, and we didn't get anything in microbiology. So that's why it's important to send to both microbiology and histology. This is an example of the PCR machine, and it's quite useful and can give you very good results in very quickly, especially with fungal infection. We can't wait, or with acanthamoeba infection. We just introduced it now in our trust to be used for all cases, not only acanthamoeba, and that's been very good. But remember, you can still get false positive results if you get contamination, and it is quite an expensive modality for investigation. It's important to know what kind of organism you're getting in your center. So, for example, we did this in Nottingham, and we found that the Staph aureus is most common, and acanthamoeba is less, and Pseudomonas is even less. It's also important to determine the risk factors that you've got. So, in a place where a lot of people wear contact lens, and that's a big risk factor. In a center like ours, where there are a lot of ocular surface patients are there, so that's a big risk. And also, based on that, you decide what works for you. So not necessarily what works for one center is likely to work for another center. For example, we've done this study, and we showed that there are similar results whether we got to identify the bugs or not. We have similar results because we know the kind of infections we're getting. We have standardized our techniques of treatment, and with this technique of treatment, we potentially achieve very good results with up to 85 to 90% of cases. So that's why it's important to know what kind of bugs you're getting mostly in your center. And that's just to show you that in a different setting, when I was in Egypt, we did similar studies, and we found that 43% of patients had fungal infection. So we changed our initial treatment from vancomycin and ceftazidime and added itraconazole twice a day. So we started straight away with antifungal for all cases because we have such a high fungal infection rate with these patients. So that shows you the importance of knowing the kind of microorganisms you're getting in your center. So how do we make bad better? So first you assess the patient and you've examined the patient, and then decide, is it site-threatening or is it not? So if you get a peripheral ulcer, non-site-threatening, you can start with monotherapy. But if you get a central ulcer like this, which is site-threatening, or a patient immune-compromised, or bilateral, then you know you've got to stop everything, admit the patient, scrape the patient, and intensive dual therapy. So in site-threatening ulcers, our top protocol is to use an aminoglycoside and cephalosporin. So one to cover gram-positive and one to cover gram-negative, and we usually use it daily, hourly, day and night for 2 days, then hourly day only for another 5 days, then reduce according to the response of therapy. But in small peripheral ulcer, we can use fluoroquinolones. We like levofloxacin because it is preservative-free. So less toxicity, but for more severe, we usually sometimes use amoxifloxacin, which is a 4th generation. We don't tend to use systemic antibiotics unless the sclera is threatened. We use doxycycline quite often because it's a protease inhibitor and it reduces the melting. It's important to use mydriatics, atropines, or cyclopentolate to relax the ciliary muscles. And when we use anti-glaucoma, if the pressure is high, we like to use oral acetazolamide because the trabecular meshes are usually clogged by inflammatory cells. And so you want something to reduce the aqueous formation rather than increase the aqueous outflow. And we sometimes use analgesics, paracetamol most likely. We don't like to use non-steroidal anti-inflammatory because of the response on the cornea. If you have deep-seated abscess like this one, the patient with a very deep-seated abscess, luckily we got results from microbiology that is Pseudomonas, and he had a large ulcer like this. And we've decided that patient needs intensive treatment because he was also single-eyed, and this was his good eye. And then eventually he improved, but he stopped improving. And for 2-3 days, the patient stopped improving. So we decided to go and give him intrastromal injection of amikacin 0.4 milligrams per 0.41 mil, and he had 4 injections, and the infection is completely settled. Then the epithelium was not healing, so we put a multi-layer amniotic membrane, and within 1 week he was completely healed. For fungal infections, amphotericin B is good for candida, but if you have filamentous, then you want something like natamycin or the azoles. The natamycin is commercially available, so that's an advantage. However, it's quite toxic and a lot of patients don't tolerate it, and it is not very broad spectrum and does not penetrate very well. So the azoles penetrate much better, and the itraconazole can be taken systemically. I don't have quite enough, I don't have enough experience with echinocarditis, but some people have used that successfully. Voriconazole we use quite often as topical drops and as a first line presentation because it's quite broad spectrum and it penetrates quite deeply. And if you have a leathery edge like this, then it's very difficult for the antifungals to reach the infection. So it's important to do a keratectomy to remove some of the fungal load as well as allow the antifungals to penetrate deeper. So that's an example of another patient who had fungal infection. We gave him antifungal and the patient initially responded and the infection was reduced quite a bit to that area, but he was thinning, and then suddenly he started to get worse. And at that point, because we know that it's definitely a fungal infection, we started giving him intrastromal voriconazole, and the patient had regular daily intrastromal voriconazole for maybe 6 weeks until he completely settled. So we're finding more and more these intrastromal injections quite successful, and you can reduce the drops because you don't have to give them hourly anymore, and we get very good results, especially in deep-seated infections. For acanthamoeba, usually like a combination of one of the biguanides, such as PHMB or chlorhexidine, and one of the diamidines, such as boluene. The boluene is quite toxic and quite a few patients will not tolerate it, but you really do need the combination if you can. And because one is cidal, so the biguanides are cidals to the cyst, while the boluene is static, so it doesn't kill the cyst. So that's why you need the biguanides with it. People have used neomycin, but remember neomycin is quite toxic to the epithelium, and you might end up with a non-healing epithelial defect, and you think that's because of the acanthamoeba, where actually it is because of the toxicity of the neomycin. Voriconazole has also been used. I don't have much experience with some of the anti-cancer drugs that have been recommended, especially if the disease is systemic. And if nothing works, then remember there are all these old therapeutic modalities such as povidone iodine, chemical cautery, or silver nitrates. We hardly use these drops, these now, but in areas where your antimicrobials are not available, then these are also good therapeutic options. People have used thermal cautery or cryo applications, or done keratectomy, especially as I told you, like that patient with shield ulcer. The future is in antimicrobial peptides. So these are peptides and proteins which are available on your ocular surface in your tears, or they can be synthesized by the epithelium or some neutrophils. And they have antimicrobial abilities. And people are now working to try and use these antimicrobial peptides to treat infections, whether they work directly or whether they can modify them to enhance their penetration or enhance their activity, or sometimes people are trying to put these antimicrobial peptides in combination with antivirals or antibiotics and see the effects. So it's still in the process of development and not there yet, but it can be the answer for multiple microbial infections as well as antibiotic resistance. So if you see the patient's symptoms and signs worsening, then you've got to stop everything and take a biopsy. And you need to take a biopsy from the deeper infective tissue. For example, that patient who had a DALC and had deep infiltrate, which got better and worse and better and worse almost over a year, and is not completely settled. So we had a superficial keratectomy with the biopsy punch, and then took the biopsy from the deep surface underneath, and it turns out to have an infectious crystalline keratopathy, and that patient had to go on and have a penetrating graft to get rid of the infection. So it's important if you've got worsening symptoms and signs, to stop every treatment for 24 and 48 hours and do a biopsy. So if you have worsening after initial improvement, think mixed infections. So you can have a combination of infections. So again, stop and re-scrape. Check your drug sensitivity with your microbiologists and think of drug toxicity. So if you have redness which is much more inferior than superior, then you know that you're starting to get some toxicity, especially if you put fluorescein and you see conjunctival staining. And the toxicity will prevent the ulcer from healing. So then you have to reduce your antibiotics or think of other modalities such as interstitial injections. Steroids is quite a debatable question when to use them. Certainly in certain situations, but only after definitive response to your treatment is seen. So only if you see actual absolute response to your treatment, so you know that you're treating the right bugs with the right antimicrobials, you can start steroids. I would give once a day or then maximum twice a day steroids. I don't give more than that. And you can see a very good improvement in the inflammatory response. And especially if you've got a graft or you've got scleral involvement, then you need to use steroids earlier. So that's, and so corneal cross-linking, quite a lot of case reports, few randomized controlled trials on corneal cross-linking. And the way corneal cross-linking works is that it strengthens the cornea, and the reactive oxygen species that is produced will damage the DNA and RNA of the microbes and increase the cytotoxicity. However, the keratocytes are also damaged. And we've done a randomized case control trial, and was one of the first ones reported in the literature, where we tried collagen cross-linking with antimicrobials in comparison to non-cross-linked groups where we give only antimicrobials. And we didn't find much change in the time to healing. However, the patients who did not receive cross-linking had higher rate of complication. And this is an example of one of the patients at presentation getting worse, and then eventually had cross-linking. And you can always see that increased reaction after cross-linking is called Herxheimer reaction because of the cross-linking. The inflammation is increased. A lot of microbes are dead, so you see increase in hypopyon and increase the AC reaction, and then eventually everything settles and the patient heals. Again, another patient who's had post-LASIK infection, which turned out to be fungal infection, where the flap was amputated, the patient was cross-linked and treated with antifungals, and finally settled completely. With a contact lens, he achieved 6-9 vision. So the advantage of PAC CXL is that to reduce the melting, and with that you reduce your need for hot grafts if things are going downhill. It is an adjuvant to antimicrobials, especially if you have antimicrobial resistance. It is, from the literature reviews, it is effective against superficial bacterial and potentially superficial fungal infections, but not as effective in deep infections. There is no verdict on acanthamoeba yet, so mixed reports in the literature. And it is definitely to be avoided in viral infection because it can lead to reactivation of herpetic infection. And it is not without problems because there is an incidence of infection. You're creating a huge epithelial defect, so there is a big incidence of infection, and you can get eventually scarring, which requires further therapeutic grafts with cross-linking. Now, if you got a perforation, then gluing is the answer, the initial, especially if it's a small perforation, less than 3 millimeters. And you can see here the AC is all flat. So even if it's a small disconnected seal, you have to use 2% fluorescein to check for leaks. So 2 clues leaks for perforation. If you do a Seidel test and you see a perforation and you put your hands on the globe, and you can see a very soft eye. This is an example of good amount of glue application, and this is an example of too much glue application, and this causes quite extensive reaction and quite extensive irritation to the patient, and often it will be dislodged and it will create entangled mucus. So it's very important to remove all the debris and all the discharge and apply just the right amount of glue on your perforation. And you can also use the glue to seal perforation just before you're doing a therapeutic graft, because you need a firm globe to be able to refine. So this is an example where they had multiple areas of perforations. We used glues to seal the perforation and the therapeutic graft. If you have a small iris that is coming out, then you don't want the glue to get in touch with the iris. So you use the double drape technique. So you put a small plastic drape to cover the iris, then a bigger plastic drape with the glue so that the iris is not in contact with the glue. And you can also glue at the slit lamp if you're busy in clinic. However, the disadvantage of that, if you put too much glue, it becomes very difficult to take it out. And you can put a speculum or ask your assistant to hold the lids and check exactly the point of glue. Actually, with a slit lamp, you can see very well and check exactly the point, so you can deliver a very small amount of glue to the area of perforation. When you have a leak with an active infection like this, it becomes a problem because you can't really put a bandage contact lens. If you put a bandage contact lens, the infection can get much worse, like that happened with this patient. So eventually had to take the bandage contact lens off and give the antibiotics intensively while the glue is there. When do we remove the glue? Quite often the question. So if usually within 6 weeks to 2 months, or if you start to see blood vessels coming underneath the glue or around the glue, then you know the glue is ready to come off. So you nudge it from the edge with a forceps, and then you can hold it with your forceps and it will come off with you. If you see blood vessels, definitely glue needs to come off. And sometimes you get an epithelial defect under because the epithelium cannot go under the glue, but eventually that settles very quickly. And as long as the cornea is epithelialized, don't worry. So you can also get infection under the glue. So that's an example of a patient who had a glue and then eventually developed an infection under the glue. Again, that's another patient who had a glue, and then when we take the contact lens off, when we found the viral dendrite under the glue. So it is important to thoroughly examine your patient, especially if you see redness and even signs of inflammation. And that means there's something is wrong. So take your contact lens off, examine the glue, examine to see infection underneath, put fluorescein and check for infection. Now, if you have a neurotrophic ulcer, a multilayer amniotic membrane is very useful, and we use this quite often in our practice. You don't want to put a multilayer amniotic membrane if you have melting and you have an active infection like this. You have to first treat the infection. And if you eventually end up with a neurotrophic ulcer with thinning and gold edge like this, then at this stage, you will put your amniotic membrane multi-layer. So we usually put multiple layers with glue in between, and we suture the top layer. And then you get the tissue to build up, and the epithelium will come. But you don't want to use it when you've got an active infection. This is another example of infection in a patient with rheumatoid arthritis. And eventually the infection settled, but there was a non-healing epithelial defect. You can see with OCT, the thinning, very useful, the OCT to monitor. And you can see here the amniotic membrane, which got completely incorporated into the tissue. And that's the patient in 6 months' time. And we've published on this to show that the amniotic membrane, when you put an amniotic membrane, the epithelium goes on it, the keratocytes will change to fibroblasts and myofibroblasts and pass through breaks in the Bowman's membrane. So if that's the Bowman's membrane, then the keratocytes will pass through breaks and repopulate the amnion. And that's how the tissue builds up when you use multilayer amniotic membrane. So that's another example of patients with a neurotrophic ulcer. With a simple technique, you can inject Botox and the ulcer will heal very quite quickly. This patient with a neurotrophic ulcer post-viral healed in 2 weeks' time. But remember, you don't want to inject more than once because sometimes it takes 2 days up to a week for the effect of the Botox. And if the patient had multiple injections because the lid didn't drop quickly enough, and then eventually they ended up with doses which required further surgical interventions. You can get the superior under action, reduced bells, persistent diplopia, or persistent doses. So these are some complications of Botox. Tarsorrhea is the gold standard for neurotrophic ulcers. It is unsightly, not every patient wants it, but it is the utmost effective treatment for neurotrophic ulcers. And these are examples of tarsorrhea where the ulcer usually heals quite quickly. I quite like the pedicle flap, especially if there is not visual potential or the patient is diabetic and you know the epithelium is not going to heal, or the patient is not putting the drops properly. So you take a pedicle from the limbus, very thin, only the conjunctiva, and rotate it, make sure you've got blood vessels within the base of the pedicle. and then you glue it and suturing. And within a week, you'll find the ulcer healing. These are examples where this is a lost eye where we use the pedicle flap, but this is also an active infection where the patient was not putting the drops and it was diabetic, and we did a pedicle flap and settled very well. Because if you want a quick result, then this is how it looks immediately post-operative, and this is how it is when it completely settles. If you want a quick result, or perforations happening so quickly, or your patient's not putting the drops, then pedicle flap is a very simple and inexpensive modality to treat infections. But if you have a lost eye like this one, and you can use a Gunderson flap to cover the epithelial surface. You can use a Gunderson flap earlier than that, and eventually you can remove the Gunderson flap and do a keratoplasty after that. There's always a very nice plane between the conjunctiva that you put on the cornea and the actual corneal surface. If you have a large perforation like this one, then you really need to take the patient straight to theater. So in that case, the patient was taken straight to theater, and a large glue was put in a preparation for a therapeutic graft. And then a therapeutic graft, partial thickness sclera, full thickness cornea was done. And once that settles, you can always go and do a visual graft after that. So some patients, you just have to go for a therapeutic graft, and it's important to decide, make the right decision when to do that. Because sometimes if you leave it too long, then things become much more difficult, and you get a lot of inflammation at retrocorneal membranes with the graft. So it is important to take the decision in the right time. So to better manage infectious keratitis, you have to have a systemic approach to your history and clinical examination. We have to think of improving our diagnostic techniques, because whatever we've got at the moment is not good enough. We have to have specific antimicrobials, so we still have fortified drops that we make ourselves, anti-acanthamoeba, antifungals, nothing much off the shelf, which is broad spectrum, so we need more research into specific antimicrobials. The new frontiers are the antimicrobial peptides, so this is all in development, and a lot of researchers are ongoing to try and put this into clinical practice. Collagen cross-linking is there to stay. However, we need more standardized protocols, and we need more evidence through randomized controlled trials on how it works, where it works, which protocol works best, and when not to use it. So good is getting better, but we still have to work hard to get the best treatment for microbial keratitis. Thank you very much.
Thank you, Dalia, for this very informative talk. And there are a few questions that comes in, and we would like to start this discussion with you with the hot topic of COVID. So we know that you are like a referral center from the area around you in Nottinghamshire. So have you seen any COVID-related keratitis or COVID-related corneal infections?
To be honest, this is actually, we are in the process of publishing this, that yes, but the answer to this is yes. We have seen infections related to COVID, and we're just trying to ascertain that it is related to COVID, or related to COVID vaccines actually, as the ones that we are seeing at the moment. And we're trying to collect these patients and make sure that the coincidence is there, and it's not just a coincidence. And yes, we have seen quite related COVID keratitis related to COVID. So
is it related to an actual infection, or you think it's related to the change of the immune status of the body?
No, I think what we've seen related to the COVID vaccine, so post-COVID vaccine. We haven't seen infections related to COVID of the cornea, conjunctivitis, not serious infections. We haven't seen that. But now every time we see some certain cases with infections, we do ask about the history of COVID vaccine and the duration after the COVID vaccine. So usually after a week from that, within a week, the patients will get reactivation of infections.
Yeah, there is a lot that we probably will see in the next months or years. We've seen what's happening in India with mucormycosis now, and inoculations starting. So there's a lot still to see coming from COVID. So with you've showed a case of fungal sclerokeratitis, and you mentioned something about systemic antifungals and systemic immune suppression. Is that oral steroids? Would you combine both together?
So for fungal infections, I don't like to give systemic steroids, but for acanthamoeba, you have to give systemic steroids, systemic immune suppression. So for fungal infections, we give them, we have to do baseline bloods. So do you baseline full blood count, liver functions and kidney functions, and we give them therapeutic doses of voriconazole. And we monitor the bloods, the kidney and liver functions routine every day for these patients. And and they respond well. But for acanthamoeba, it's not enough to give anti-acanthamoeba. You've got to give systemic immune suppression if the sclera is involved, because otherwise the inflammation will destroy the eye.
And is that in the form of oral steroids, in the form of cyclosporine,
not steroids,
tacrolimus?
No, we work with the rheumatologists. And actually, we had a patient who developed scleral abscess. Acanthamoeba, known acanthamoeba, we've been treating her, that she developed scleral abscess, and she had to have azathioprine, I think, and then she had some complications with that. So not steroids, but actually steroid-sparing immune suppression.
So you'll get rheumatologists on board, involved with the treatment.
Yeah.
Okay.
If we get acanthamoeba with reaction, we give them steroids topical. We give topical steroids intensively together with the anti-acanthamoeba. Then we try and taper the steroid gradually until the patient is completely off steroid before we stop the anti-acanthamoeba.
Okay, so what's your view on a protocol where you can give PHMB once you have diagnosis of acanthamoeba? You start with PHMB and topical steroids. What's your view on that?
So the problem with the steroids is that you can get resistance. So some people will say you give steroids so that the cysts turn into tophozoids, so then you can treat them. But I found that in a lot of patients will become steroid dependent, and it becomes very difficult to take the steroids off. And every time you take the steroids off, you get severe inflammation. So I don't like to give steroids for acanthamoeba unless I have uveitis, topical steroids. So if I have a uveitis, then I have to give steroids, and I'll give a short course of steroids, and I'll try and taper it as quick as possible.
Okay, and regarding the scraping or re-scraping, if you have a patient who comes to you presenting who are already receiving some intense topical antibiotics and not getting better, you're not sure of the organism, how long do you recommend stopping before scraping or re-scraping the patient?
We usually say 24 to 48 hours. So if there is no melting and you're not worried about perforation, stop for 48 hours. But if you've got a lot of thinning and if you're going to stop for 48 hours, you're likely to perforate, then the minimum would be 24 hours.
And you've shown as well interesting cases where you've said this could be monotherapy, but if there is some threatening visual keratitis, so what you can do is to give dual therapy and consider admission. What's your patient selection for admission? You don't admit everybody.
We admit. So if it's a central, or it's bilateral, or the patient is immune compromised, or I'm worried that the patient is not going to put the drops, they've got rheumatoid arthritis, they can't put the drops. Any patient like that is for admission. But fortunately, we've got the ability to admit patients, not in every place. I think admission is very useful because you can monitor the progress of the change and the changes, because patients can get better and better and suddenly start to get worse. So you have to monitor your treatment almost on a daily basis, and that becomes much easier. And also the other thing is, if you send the patient off with drops and they get worse, you don't know whether they're getting worse because they're not putting the drops, or they're getting worse because the antibiotic or antimicrobial is not working. But if they are admitted, then you know for sure that they are being given what you've prescribe for them. And if they're getting worse, then you know something is going on.
And do you always admit in like a side room in isolation for these infections?
Yeah, we try and tend to isolate and admit in a side rooms for all infectious patients.
Okay, and with you using amikacin, it looks like you have big experience with using amikacin, which is not first line in lots of centers. So is it the 2.5% or the 4% that you prefer?
No, 2.5%. We use topical 2.5%, and only very recently I've started the intrastomal injection, and I use the intravitreal concentration. That I don't, because amikacin is very toxic. And if some goes into the eye, then you can get retinal toxicity, you can get retinal hemorrhages. So I have to be very careful with that. And I don't like to give multiple, but I found that in very deep abscess, if I inject 0.1 mil into the abscess, then I get very good results, very quick response.
But
because all amikacin is quite toxic to the surface. So if you keep putting the drops at a high frequency, you get a lot of ocular surface.
But you use lower concentration. So if you for intrastromal. Okay, then another interesting case you showed about the leathery plaque that you said you're going to remove to reduce the fungal load and to allow the drops to penetrate better. So in such a dense plaque where you can't see what's underneath, would you attempt to remove it on a slit lamp and risk perforation, or is it better to take patient to theater and do that there?
No, I always take the patient to theater. And if you have an OCT, you can also do an OCT before. Then you will see the leathery edge and you see how much behind it of corneal tissue. But I always take that patient to theater. Then you have it's much more controlled. You can do it under topical anesthesia, but take it to theater, use a crescent blade, and make sure you just be careful in taking this. And if you have a problem, then you'll be able to manage.
Would you send the plaque to the lab, microbiology?
Yeah, definitely.
Even if you have confirmed culture, you still send?
Yes, absolutely. Oh. Even if I confirmed culture, if I'm doing a biopsy, I would still reculture.
That's very good. Artemis, you have questions at your end?
So question would be about amoeba keratitis. How long do you continue the treatment for? What is the duration of treatment?
We usually start with the treatment combined therapy. So one biguanide, one of and usually propamidine with it. Hourly, day and night for 48 hours, then hourly day only for 5 days, then we reduce to 2 hourly. Now 2 hourly can be for a month or 2 months, depending on the response to therapy. And then after that, you can carry on for at least 6-7 months after that. And we try and take the anti-acanthamoeba off very gradually. We put steroid if we get uveitis, then we give topical steroids with it. But we try and take the anti-acanthamoeba very gradually after that.
Mm-hmm. And another question is, at what point do you decide to give intrastromal injection of antibiotics?
If I have a lot of ocular surface toxicity, and I don't want to, and I have a bad infection which is deep, so the deep infection will not settle with 4 times a day antibiotics or antifungals. So either you're going to have to give intensive treatment, or you have to go and try and reach that posterior abscess with something else. So if I'm starting to get ocular surface toxicity, I want to reduce my drops. So I substitute that with intrastomal injection, especially if you have a deep abscess.
Mm-hmm. And a question that I have actually about your experience using crosslinking for infections with melting. Are you using it in your practice? Is that something that you've seen good outcomes with?
We use it in our practice, not as commonly as we used to use it in Egypt, because in Egypt patients presented very late, a lot of melting, and we didn't have all sorts of antimicrobials that we require. So we definitely try to cross-link them to try and stabilize the cornea at least. Here in the UK, patients are either presenting at a stage where we control the infections, or now with COVID, they're presenting with perforations.
So too late for this. Yeah.
Exactly.
Yeah. I think these are the questions from the audience that we have at the moment. So I don't know if Mr. Elalfy wants to.
I want to thank Dalia so much for giving us the time. It must have been a long day for you, and I think we are good within our time frame for this webinar. I would like to say Happy Eid to you and anybody who's celebrating tomorrow as well. And I think we don't have an announcement for the next one, Artemis.
Yeah, so the next one we will confirm to everyone who is interested over the next few days, but the date is set for the 9th of June, so save the date. Topic is to be confirmed. And thank you so much for Professor Said for being with us tonight. Thank you, Mr. Elalfy. And thank you to our audience, because they're watching both on Facebook and on Zoom. So thank you for being with us.
And thank you, Artemis, for hosting.
No problem. Thank you very much. So I think we're within time, actually. So thank you for a very, very concise and very, very thorough presentation, Professor Said. We'll see you next time. Looking forward. Okay. So good night, everyone, and thank you. Bye.
Bye.
Bye.